This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best. Hello and welcome to the Nupsala podcast. In this episode, we invited two of the speakers from the Veterinary Osteoarthritis Alliance conference to have an open discussion on the uses of 2.5% polyacrylamide hydrogel in canine osteoarthritis management. Dr. Jason Lowe is the Chief Veterinary Officer for Contura. Jason has over 30 years of clinical experience in equine clinics throughout the world. After obtaining his veterinary degree from Massey University in New Zealand, Dr. Lowe embarked on a journey to specialise in equine medicine. He completed a certificate in equine practice from the Royal College in London and a Master's in Business Administration from Waikato University in New Zealand. Dr. Lowe's expertise encompasses a wide range of equine health issues, and he is actively engaged in research efforts with 2.5% polyacrylamide aimed at advancing equine performance medicine and improving the lives of horses worldwide. Dr. Alexandra Keller is a veterinarian based in Frankfurt, Germany, with a special interest in small animal orthopaedics, sports medicine and rehabilitation. She's the founder of a dedicated orthopaedic and rehabilitation practice focusing on the diagnosis and treatment of musculoskeletal conditions in dogs and cats. Her main areas of interest include advanced orthopaedic diagnostics, sports medicine, osteoarthritis management, and modern joint therapies, with a strong focus on multimodal and conservative treatment approaches. Alexandra combines diagnostic techniques such as objective gait analysis and musculoskeletal ultrasound with individual treatment plans to improve mobility, performance, and quality of life. She's also actively involved in the continuing education and international collaboration within the field of veterinary orthopaedics and rehabilitation.
Yeah, Jason Lowe, Chief Vet Officer at Contura Vet, here with Alex Keller. I guess the biggest question we always get asked, isn't it, Alex, is around what actually is 2.5 iPAAG. I had the pleasure a couple of weeks ago of being at a researchers meeting. We brought together a group of around 12 researchers across human and veterinary medicine, and we've really got to that stage now. It's recognised as a mechano-modulating synovial implant. And I think when we really get that into our heads as veterinarians, we can really start to understand where the product sits, our treatment strategies when we're dealing with these lame animals and with humans as well. When we go into the technical side, that it's a 2.5% polyacrylamide hydrogel and 97.5% of it is water. I think, again, understanding these are sort of small, about 500 micron balls or spears, if you like, of injectable hydrogel. So once you've injected it into the joint, the way it moves through the intimal layer of the synovial lining and into the subintima is just purely part of that natural passive process of how the joint clears debris and stuff anyway. But again, I just like that concept, this really soft viscoelastic hydrogel moving into the subintima, restoring that capsular elasticity, which we've got some good data on. But
yeah.
Does that sort of make sense to you?
That made absolutely sense for me. And to see that from the practical experience or from the practical standpoint, we have got so many osteoarthritis dogs. So we have got more than 80% in dogs over 8 years and 20% in dogs around 1 year. So for us, we need a game changer. And it's a game changer because it's not like a modulation, some of the biomarkers. So it is more the restore the whole function of the joint, and we can start really early in treatment without a severe side effect. So
yeah, I think,
really
and it's interesting, isn't it, how we've sort of had it in equine medicine, and that's my background. I know you started off there and then moved into canine. But yeah, we've sort of accepted intra-articular therapy in that part of veterinary medicine for decades, really. But it seems to be a relatively new concept in canine medicine.
So I think a big point is that we have got other point of view on the joints in the small animal world, because we do a lot of surgeries in joints. And on the other side, we have got a lot of veterinarians, general practitioners. They are a little bit afraid to touch joints. They are afraid to inject. And I think one big point, the third point, is that we do not have a lot of research around using it in the small animals. And in the last time it comes up from Matt Brunke, and so we have more data, and it's so more useful for the dogs.
Yeah. Again, it's something that my role as CVO coming into the company, I've really been pushing that side. So we've got some great research coming shortly. Obviously, you and I have actually been collaborating on some of your data, which is great, and we'll have more of that coming out soon. Like you say, Matt Brunke and his team in the US starting to publish some data now. So it builds on the back, I guess, of the human data as well as the equine data. But overall, this product has been used in medicine for 25 years. It's actually not new technology. It's not as new as people think it is.
Yeah.
And I guess that's what I really get to understand, that it's safe. There's literally millions of doses have gone into animal tissue and human tissue over 25 years. So I think that should give a lot of confidence.
Yeah.
And you think that is the main barrier for canine veterinarians, is just confidence or fear of the product or the technology, or is it just doing intra-articular injections in general?
I think it's both. I think one thing is the technique to do joint injections. So if you're not a surgeon, you are not really used to it. And the general practitioners are a little bit more afraid maybe to do the injection. We do not have so many trainings outside to learn it. But from my practical point, I can say try it for your own. If you have got a dead animal at your practice, you can immediately do a joint injection and you can learn it. It is not so difficult, definitely not. The other thing maybe is, especially in Europe, that the iPAAG is not licensed, and you have to use the cascades to do it individual for a patient. This makes not so much comfort, I think, for some of the vets.
Yeah, it certainly makes it harder. And again, obviously, we have to follow those legal channels and regulatory requirements. But I know that Contura are working hard on that, and that's part of my role as well, which is we will get there. I'm actually running a pivotal study in Australia at the moment in canine OA. We've recruited about, I think 39 dogs actually have just entered the study. We're looking around 40 to 50 dogs, and that'll be for a label extension to our current registered product label, so into dogs. So yeah, the data's coming, the research is coming, but it does take a frustrating amount of time.
Yeah, but I think that will be helpful. So I think we have a lot of cases for iPAAG, and to be the best case, I think that's not easy to answer. What is really important is that you have got a good diagnostic possibility, and that should be in an end stage or in an early stage. And with new technologies, we have got better possibilities to see the osteoarthritis changes in dogs much earlier. So if you think a little bit about radiography, it is that you have got osteophyte changes in the joint. That is more the end stage. And with using ultrasound, with using maybe gait analysis, with new techniques, we can get the patients much earlier. So that would be a great success if you think about the use of iPAAG, because we can interrupt the disease much earlier and prevent the degeneration a little bit, at least. Sometimes a little bit more. It depends a little bit when we get them. So focus on joints. Normally you can use every joint, of course, but we can focus in the dogs on elbow joints, on stifle joints, on hip joints, and only think about these 3 joints. It's such a benefit to use a local therapy and not only using medication or surgery. So it is a huge impact in every stage of the disease.
Yeah, I think it's something we were sort of talking before about equine compared to canine, and again, I think it's something that equine practitioners, that early intervention is just what we do, because it's suddenly performance limiting. That's the reason that clients approach us and get us to examine their horse. But you just don't see the same in the canine medicine, or do you think we're just not taking those opportunities young enough for these dogs to actually fully investigate if they are presenting with lamenesses or early orthopedic disease?
Yeah, I think still that's not common that you think about OA in a young dog. Data from research shows different results. So we have to bring the information to more of the general practitioners, that they have respect and think about early changes. And in the past, they're doing a lot of equines as well. And if I compare analyzing X-rays from the horse world with the dog's world, we have to be much more sensitive in analyzing data. With the new technologies, with the digital X-ray, we have got really nice images. But if you have little osteophytes, you say really often in the small animal world, it doesn't care, it's not so much. So you have to take care of that.
Yeah, I agree. And it's probably that whole understanding of the OA disease, isn't it? And sort of not classification, that's not the right word, but sort of OASI and groups like this that are recognising synovitis, fibrosis. Those are the early stages of OA. And synovitis is actually where the pain is coming from. It's not the cartilage. The cartilage is aneural, avascular. That's why it doesn't heal particularly well. But if we can address synovitis, and I think this is the first time ever we've really had a tool in our toolbox which addresses directly that structure. It's directly affecting fibrosis and the synovial function. And what we've shown in the recent data coming out at ICRS conferences from Colorado State and their Translational Medicine Institute is, sort out the fibrosis and the stiffness, that calms the joint down, and then we're getting these lovely downstream effects of changing the inflammatory profile of the intrasynovial space as well. So I think, again, it's understanding what the gel is, what its mechanism is, and then we can really start to pick those right cases for it. And it's not saying that you only ever use iPAAG, but I think, and would you agree, it again forms part of that multimodal approach, isn't it? You're still going to use other things as part of managing that dog throughout its life.
Yeah, of course, that's absolutely necessary. It's not only therapy, so you need it as a team player. You need it in the part of the multimodal management. And going a little step back, I think the early diagnosis is so important, and it is so important in this disease to be a little bit more proactive. Also, if you do not have all the techniques like digital gait analysis, muscle skeleton ultrasound, which could be really helpful in early diagnosis, we see changes in the joint capsule. We can examine soft tissue around the joint, different to X-rays or radiography. In the beginning, the early diagnosis is really helpful, and then using it in an early stage and put it together with a multimodal management is really, really helpful.
So what other sort of, I talk to my vets that I chat with and stuff about, start with, right, make it sort of a foundational therapy, address the synovium, target that organ, if you like, of the joint. We get these other downstream benefits. I'll also use other biologics and cortisone. Are you similar? What other products are you sort of using, or how are you putting that into your treatment pathways?
We are using different products. I'll be honest, I do not use a lot of corticoids in joint injections, but we use regenerative medicine, PRP, stem cells, and sometimes we combine it together. iPAAG, sometimes we do first the regenerative medicine and maybe 4 weeks later the iPAAG, if we have got the possibility to see the dog again.
Yeah, that's great. Okay, so we've sort of been talking as well around, well, one of the questions we get as well is around longevity, how long the treatment might last. Obviously, sometimes that's how long's a piece of string because there's lots of variables in that. But what overall are you finding in your cases?
Yeah, so this depends a little bit on the case. If we have got it in the end stage, osteoarthritic changes, I, in my experience, see that we had at least 1 or 2 years effect. But really often we do not have to re-inject the joint, because if we have got a good effect of the iPAAG in the joint, and if we have got a good reacting on the multimodal management with good muscle building, with good motion, with a good all-over function, whole dog, I would say, it's not only the joint, then we have really often dogs where we do not have to re-inject. So all over, in my experience, we treated more than 800 joints now. We have around a re-injection rate around 10, maybe 15%. It depends a little bit on the joint, but it's not so much. And we use it now since 2017.
That's really interesting, because those sort of numbers actually correlate quite nicely with the human data we're seeing as well. We've actually got 5-year efficacy data in humans, some cases even out as far as 10 years, obviously much smaller numbers in those groups. And again, around a 15% sort of partial responder rate. So those patients are getting a top-up dose maybe after a number of years. I guess in horses, we sort of see 1 to 2 years in most cases, but certainly even longer in some of them, depending on those variables. But I think that's what really intrigues me, is just the consistency and the repeatability in the data, which certainly as a scientist, it makes you understand this is real, right? This isn't some sort of trophic effect or an unknown effect. This is what this product's doing in the joint is quite a real thing.
And maybe I can jump in, because we think about longevity and how long it takes. Maybe we have to mention that it is not an injection where you see on the next day a perfect effect. So normally it takes around 4 weeks, I would say, where we can first have the first results, where we see an improvement in range of motion and where we see a improvement of loading the leg, and sometimes it takes a little bit longer. So we have also dogs where we see an effect after 3 months, really good. So it is not that we have an injection and 2 days later everything turns. So if you use it, take care in the next 3 months about what happens. Just rechecking. Sometimes if the dog is not much better, re-evaluate the dog. So maybe we have got other structures which are involved in lameness.
I think that's a really important point too, is reassessing that diagnosis, isn't it? And even sometimes you might have addressed that particular joint, but sometimes they might throw up another joint, and they've just been offloading or compensating. And I always kind of like that from a clinical perspective. It's like putting a jigsaw puzzle together sometimes. And sometimes this concept, especially for young veterinarians, you don't fix everything straight away. I think it does become a management system, but that allows you to engage with your clients and keep that relationship going. Because again, I know there might be some vets out there thinking, a treatment that lasts 1 to 2 years, what am I going to do with my day? But I know you'll find other stuff to do, right? None of us are short of work. And, and if you do run out of work, you can go whale watching or go and play with the kids or something. So I guess that brings us on to the dose rate, because again, it's a big question I always get asked, what dose are you going to put in a joint? How do you sort of manage that?
Yeah, that's what we not really know from the research now. So because I know the iPAAG from the horse world, and I think about the joint size and the stage of osteoarthritis changes. So we started with a no dose. So in a regular joint of a dog between maybe 10 and 30 kilograms, we use 1 ml in elbow, we use 1 ml in a hip, and we use 1 ml in the stifle as well. And we have got a really good success with that. Sometimes if I've got a severe osteoarthritis changes in a huge dog with around maybe 40 to 50 kilogram, where the joint is much bigger and you see this severe elbow osteoarthritic changes, I use 2 ml, because the changes, from my understanding, the changes in the synovium is completely different. The surface are completely different, rebuilt in a joint like that. But all the other joints, we use 1 ml, I would say.
Yeah, no, I think that's certainly what I would look at as well. It's not a drug, it's a device. So we can't do dose titration studies. So a lot of this is based on clinical responses, but I sort of try and get vets to think more exactly what you said, size of joint, chronicity or severity of disease. And if it's a big joint with a lot of fibrosis and synovitis going on, get as much in there as you can, because I think you do get a better effect. And whereas if you're really early intervention, and I think vets down where we are, they just started using 1 ml because it comes in a 1 ml syringe. It was probably as basic as that. But it's certainly, even 1 ml still works in certain joints and with early intervention, which makes a lot of sense as well. Again, especially I think when you start to understand the mechanism, how this product's working.
Maybe I jump in because we use it sometimes in cats as well. So if I've got a cat, sometimes I use only 0.5 ml for hips, for example. They have got on both sides, and we have got result with that. So in the beginning, I started maybe because of money-wise, because for some cat owners it was really expensive, and I said, okay, we try to do only 0.5 ml. I have no idea, but we have a good effect, and the joint is much smaller than in regular-sized dogs.
Yeah.
It works.
Do you get any pushback on cost with the product?
So as I'm working in a specialized orthopedic practice, they're used to have a little bit higher costs, and to compare the cost of an injection and the long effect to surgery or to other drugs, only if I think the dog has to use NSAIDs for the time, it's a lot of money. So I do not have so many concerns, I would say.
Yeah, I would agree. That's certainly how we find it as well. And you found the product safe? I mean, again, you sort of talked before, we were talking before about the fear of intra-articular therapies, the resistance or reluctance, perhaps, because it's not been taught at vet schools and that, like you said. But what's your sort of experience around safety?
So for us, it's really safety. We do it, so the procedure is in our house like doing a surgery. So we do it really clean, and we do not see over the years direct connected severe side effects. So we neither have a bacterial infection after, so we do not use antibiotics afterwards. For me, in our hand, it is a really safe product with not so many or nearly nothing side effects and reactions. Also, if you have got a lot of dogs with allergies and with problems with drugs, so we use this iPAAG really in these dogs with no side effects. That works good.
I think it's really cool, isn't it, that you're not getting, and we find that in horses too, there's no systemic side effects. So the horses with metabolic syndrome, it's not a risk for them. Again, through all the safety studies in humans, 3 millions of doses, it's got a great profile. Mm-hmm. I think the other, and I can talk to this, I guess, as we were chatting before, is the questions or conception that this somehow sits in the joint, that it prevents further surgery, it might harbour infections, you have to scrape it out of the joint. I've heard all sorts of comments and almost myths, well, they are myths about what this product is, but I guess it's just nice to reassure people this moves out of the synovial cavity within 10 to 14 days. It's sitting in the intima. It's incredibly biocompatible. That's the beauty of the product. It mimics, I call it biomimetic, because it mimics natural tissue, and that's what makes it so safe and just sits there quite inert, not causing any problems. The body initially sort of sends some macrophages in to take a look at it, and then quickly realises this isn't causing a problem. It's actually too big for those macrophages to engulf and start to phagocytose and break down. And after around 90 days, the gel particles are just sitting there fully integrated, blood vessels running through them, collagen fibres sitting around it and just holding it in situ. It's certainly no concern for surgeons or future surgical interventions.
And that could be really important for small animal world, because sometimes you need later on a surgery, and if it is not a contraindication that I can have a dry without a surgery to help this dog, it is a really good benefit to use the iPAAG product, intra-articular.
And that's where it's really finding its niche in human medicine too, because when you look at early stage OA, knee OA, around that 45 to 55-year-old patient, they won't get a knee replacement surgery until they're over 70, because it's socially funded and they won't fund them, plus the high failure rates, et cetera, et cetera. So you've got this massive treatment gap within that sort of 45 to 65-year-old where this product is proving its efficacy. And I think that's the opportunity with canine medicine too, and get your thoughts on that. But there's sort of that early stage OA to end stage where, like you say, surgery is possibly an option, or some of these other systemic pain relief, monoclonal antibodies, NGF, etc. But do you sort of see, again, just that opportunity between those phases, the treatment times?
I think, of course, yes. And we all know that the surgery on a joint is not a perfect therapy in a lot of cases. It's still, nobody is happy about surgeries in elbow joints or hip joints. And so we have got sometimes cases where we find problems in the joint without severe changes around. So surgery should be not the first thing what we should do.
Yeah.
That's my opinion. So,
Yeah.
and if I can use a iPAAG, for example, with intra-articular injection, which is not massive invasive, and we do not have so many severe effects around, it is a really perfect help and fits perfect in our multimodal management.
Yeah.
And slow down the progression of the disease.
Yeah, absolutely.
I think that's a big part of being proactive in this, not reactive. That is a big deal if we work with osteoarthritic patients.
Yeah, it was interesting being at the conference yesterday and hearing a lot of the discussion. I think someone put a slide up that the last decade has been about pain relief and this focus on pain, but now let's actually start looking at addressing the biomechanical function or the underlying disease issue going on, and that can be the focus for the next decade, right?
Yes, I think so. So that should be better handling the disease, handling osteoarthritis much earlier, modify the function of the joint, and the iPAAG can play a big role.
Yeah.
So it's a game changer in treating, because we restore the function completely and not removing only one or two biomarkers or cytokines. That's much better for the health in the joint.
Yeah, seems to be giving better results. So how do you approach your conversations with the owners, I guess, around iPAAG, relatively new understanding for them, or do you have any challenges or pushback?
Yeah, so it's completely different. Depends a little bit which owner is sitting in front of you, of course. But I explained that we have got like an implant in the joint. It's not that it is like a truck. It is not rebuilding. So it is built in the synovial membrane or in the joint capsule. I think I break it down to joint capsule most of the times for the owner. That's enough. And has an effect in regulating the function of the joint capsule. That's what I explain. And for me, I can explain that the injection is not such an invasive procedure. So we remove a little bit of joint fluid, we add the iPAAG in, and that works really good. So to explain. Yeah. So the
most people accept it. That's the beauty of being a veterinarian, isn't it? We have that trust relationship with our clients, and they're always guided by our treatment decisions, which is a huge responsibility.
They love the idea that we do direct in the joint treatment and not using a lot of drugs all the time for pain killing. And so they are really used to this idea that we be proactive and work in the beginning or work direct there where the problem is. Yeah,
that's really interesting. So I guess back to the clinicians, for clinicians who may feel unsure about technique or case selection, what practical advice can we give them?
I think to do a good diagnosis is really important. So make sure that you're doing a good orthopedic examination, and helpful is to do it a lot of times. So maybe use every dog you see for vaccination and touch the whole dog. It's possible. Every time the owner is happy if you do motion in every joint and you got a little bit of feeling. So practice is one big deal, and joint injection as well. You can go for some trainings. Some companies offers training, but also you can do it for your own in the practice. If you have got a dead animal, you can start to inject and be not afraid to do it. It's not a big deal.
We were lucky to be in America together last year at the symposium with a wide range of vets, right, with different experiences, and it certainly resonated with me that the take-home message from that room was, you don't be scared of this. Actually, it's not as hard as people would like to make it fun. And once you get into it, it's actually quite fun because you're seeing good treatment outcomes, you got happy dogs, happy owners, and it's just a really nice sort of business model, I guess. And obviously you've specialised your clinic into rehabilitation and chiropractic and physiotherapy, and as part of that multimodal approach, but you're able to run a whole practice just doing quite a small part of traditional veterinary science, right? So there must be a big opportunity out there for more vets to focus on that.
Yes, absolutely. Yeah, and if you think about the numbers, how many dogs are affected of OA, in which age, of course, yes.
And is that one of the challenges, that we just haven't been recognising it, or the owners haven't been recognising it, or we just said, oh, it's just the old dog, he's slowing down, and not thought about proactively intervening?
Yeah, but I think it changed a little bit with the social media. A lot of owners are informed over the social medias as well, and they go to the general practitioner and said, okay, I think my dog has a problem. So it changed a little bit, and only the vets has to react on it. That makes it easy. And also they can think about being a little bit more proactive. So normally they see the dogs at least once a year for vaccination, and if they bring in orthopedic examination or a little bit of questions, could it possibly be that the dog is limited in the musculoskeletal system? So that helps to recognize the dogs much earlier, or the patients much earlier.
I look back when I went through vet school, we didn't even really get much dentistry, but now dentistry is a massive part of veterinary practice. Right?
Yeah, that's true.
And I do sort of wonder again, looking at the questions, where do we see the role of 2.5 iPAAG in the future? I see canine OA as becoming a massive part of what veterinarians do, because, as you said, it's recognised as such a big problem. Once the owners become much more aware that there's something they can do about it, and they don't want to accept their dog just slowing down, because there's all sorts of quality of life issues around that, right, for the owner and the dog. So I think it's a really exciting time to be getting into this space, which is good.
And I think the position of the dogs or the animals changed completely. And so for the owner, the dog is much more than a dog. So it's sometimes it's a friend, sometimes it's for going for sport, sometimes it's a partner, sometimes it's instead of having kids. So it is a huge position for the dog. So the owner wants to do a lot for the quality of life. We only have to mention it, that the dog maybe is not only old, maybe it's painful, and we can start early.
So for both of you, 3 things that you would like people to take away from this, the 3 things that you think are the most important about using iPAAG AK908.
Okay. So I think the most important first thing is to be proactive. Try to do an early diagnosis in OA and do a good and specific diagnosis, which joint is affected, is 1 point. So proactive and early diagnostic. Second point is think about direct therapy, intra-articular injection. Think about iPAAG as an implant to restore the function of the joint. We go back and make a better motion, a better whole biomechanic. The third point is iPAAG is not standing alone, or intra-articular injection is not standing alone. It's a team player. You need multimodal management. You need reassessment of the patients. That's the third point. Fourth point, do not be afraid of joint injection.
Yeah, and I guess I agree with all that. And the only other one I'd add is safety. People should have zero safety concerns about this. And please, if you want to look at the research, dig into it, reach out to me, to the company, to other people that are using this every day. And like you say, we need to open our minds up to this, because it's going to be a big future to play going forward.
Thanks for tuning in to the Nupsala podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.